So, good morning. I'll give you guys just a quick breakdown. What I do, I'm a pharmacist at Center for Addiction and Mental Health, and I work on a unit called the Medical Withdrawal Services. It's a 12-bed inpatient unit where we provide medically supervised withdrawal management, and we typically treat patients with substance use disorders, specifically alcohol use disorder, opioid use disorder, benzodiazepine and sedative use disorder, and polysubstance use. So typically, patients stay there for an average of approximately 7 to 10 days, and then they're discharged back to the community or a residential program afterwards. So I'll be giving talking for two sections. The first section we'll go over today is called Strategies for Engaging the Patient at the Pharmacy. Let me see. So the learning objectives for this section are to describe public health risks associated with opioid use, risks and protective factors for developing opioid use disorder, describe treatment strategies for opioid use disorder, consider cultural differences when discussing addiction and use of methadone and or buprenorphine naloxone with patients, communicate effectively with patients using MI. So with regards to opioid overdose risk, very simply, we know that the risk of opioid overdose increases as the dose increases. There's also an increase of overdose risk with a history of substance use disorder, or obviously active substance use disorder, and concurrent issues also. So if you look at the chart right next to on this slide, you can see that when the opioid dose is relatively low. So if you look at the bottom left corner, you can see less than 20 milligram morphine equivalents per day. The risk of fatal overdose is approximately 0.1% per year. But as the dose increases, and in this case, if it's over 100 milligrams per day of morphine equivalents, it can increase up to 0.23%. So again, just to keep in mind, takeaway basically is that as you increase the opioid dose, there's a higher risk of overdose death, accidental overdose, opioid overdose. So this is a chart just showing a percentage breakdown of where patients obtain their opioid medications or pain relievers. And again, if you look at this chart, you can see here that obviously the biggest component where it says 54% is the green section, where it shows that they were obtained from a friend or relative for free. Again, also, if you combine it with a couple other sections, if you look in the 12.2%, you can see that was bought from a friend or relative. And then if you look at another section, 4.4%, says that that percent is taking from a friend or relative without asking. So again, if you combine all these sections up, you could see that over 70% of people are obtaining their opioids and pain relievers from friends or relatives. Again, may not be what you think. If you look at people obtaining them, maybe possibly purchasing from other people that they don't know from the street, or double doctoring, that's not the most common way that people are obtaining their opioids. So again, why are we concerned about the opioid use? In 2018, there were 4,460 apparent opioid-related deaths. The vast majority, 94%, were unintentional. And we could see now that as time is going on, there's a greater amount of fentanyl and fentanyl analogs, which are primarily responsible for a lot of these overdoses. And again, you could see from 2016 to 2019, there were over close to 13,000 Canadian died from an apparent opioid-related overdose. What causes addiction? It's a mixture of factors which include the neurobiology, genetics, adverse childhood experiences, mental health issues, stress, and also cultural differences. So when we're looking specifically at youth, risk factors for substance use and addiction in youth can include things such as family history of alcohol or other substance misuse problems, poor school performance, poverty, stress, not fitting in socially, a history of emotional, physical, or sexual abuse, and experiences of discrimination or oppression. Some protective factors for addiction include having a good or positive role model. So that could be a parent, a relative, or a teacher. Strong attachment to family, school, and community, having goals and dreams, and being involved in meaningful activities such as structured sports, music, and volunteer work. So treating opioid dependence, the benefits include less illicit drug use, better general health, better access to healthcare, greater ability to acquire and maintain employment, less reliance on public assistance, and overall better social functioning. Also, there are less spread of infectious diseases, fewer deaths, less violence, less theft and property damage, safer communities, lower health, law enforcement, and social assistance costs. So when we're looking at harm reduction, there are two ways we can look at harm reduction. So we can look at harm reduction through the patient's perspective, and we can also look through it through the system perspective. So when we're looking at opioid use harm reduction through the patient perspective, there are a number of things that we can recommend for the patient. Number one would be a safer route. So an example of that would be if a patient is using IV injection for their opioids, we can offer a safer route of maybe chewing their tablets, swallowing their tablets ideally. So these are options of harm reduction we can offer to the patient. Another option is substituting their drug of choice. So again, if we know that patients are obtaining their opioids illicitly from the street, using fentanyl, which is obviously very dangerous and a high risk of opioid overdose, we could maybe suggest that they use a safer supply or prescription medications as their drug of choice over fentanyl. Reducing their quantity or frequency. So again, if their patients are using IV opioids, they're typically using 4 to 6 times a day. So we could, if we switch them over to oral tablets, they may reduce their frequency of use throughout the day. And then also if they're using, let's say, a couple points per use, so up to like a gram a day, we could recommend that they try to slowly reduce their quantity over time and taper their dose. Also, never sharing. So we always recommend never sharing, avoiding mixing drugs together. Mixing drugs when combined, opioids when combined with other substances such as benzodiazepines or alcohol, the increase of opioid overdose increases dramatically. So again, if they're going to use substances or drugs, we recommend just using one. And then also, we always recommend never using alone. So we always recommend that if you are going to use, ideally use with another person. If they're using with another person, obviously you're not counseling them to both use at the same time, but one person uses and the other person is there to monitor them if they have any signs and symptoms of opioid overdose, then they can offer some help. Another option, if there's nobody available for them to use at the same time, then they can maybe sometimes contact message a friend and let them know that they're going to be using, and so the friend can maybe call them in a few minutes just to follow up and make sure that they're okay. When we look at harm reduction for the system perspective, we have options such as opioid replacement therapy. So obviously those are options such as methadone or buprenorphine and buprenorphine naloxone. We have needle exchanges. So again, if they're using IV, we can offer them clean needles. And also, if these services are available in your community, you can give them information about safe injection sites and overdose prevention sites. From the pharmacy, we can always counsel patients and provide take-home naloxone kits. So those are the opioid overdose prevention kits, which are available either as injections or nasal sprays. And then specifically, I guess, for fentanyl patches, we have the Patch for Patch program where patients are returning used fentanyl patches back to the pharmacy. So when we look at treatment options, we have structured opioid therapy. So what that means is there are options that we can provide for the patient, which are a little bit safer. So those can include a gradual dose reduction. So if a patient is still using opioids, we can offer options to gradually reduce their dose over time to reduce their opioid overdose risk. And we can also provide information about opioid rotation. So we know with opioids, when you switch from one opioid to another, there is incomplete cross-tolerance between the two opioids. So for example, if a patient is using hydromorphone, if we switch over to a different opioid such as morphine, we can often reduce the total morphine equivalent dose, so the total overall dose of their opioids, by just switching from one opioid to another. When we're looking at opioid agonist therapy, there are options. We have methadone and we have buprenorphine naloxone. And then we also have buprenorphine, which is the subcutaneous injections also. So a little bit more about the structured opioid therapy. When we're selecting opioids, we want to choose for the total dose. We want to make sure, if this is a new start and they haven't been on opioids in the past, we want to make sure that the morphine equivalence is less than 50 milligrams per day. And then also when we're dispensing opioids, this is very important. We want to make sure that we're not dispensing large quantities at one time. So again, depending on the patient, depending on the indication for the opioids, we can either dispense daily, observed, or dispense daily, a few days supply at a time, or up to a week or maximum 2 weeks at a time, again, depending on the indication and the use for the patient. In terms of monitoring, we have different ways to monitor their compliance with the opioids. So obviously, we have access to urine drug screens. So those are tests that we can do, again, depending on their length of treatment. We can do it as frequently as we feel necessary. We can ask for pill counts and patch returns. So these are good tools to monitor if you're concerned about the patient using the opioids appropriately. If they're being dispensed a week or 2 weeks at a time, you can ask for them to bring back their opioids sometime during that time frame, and then do a pill count to make sure that they have the appropriate amount of opioids remaining. And then, as with kind of any medication, you want to evaluate the effectiveness of that medication, in this case, specifically opioids. So you want to evaluate that with the patient frequently, ask if they're having any side effects, any adverse effects, and always weigh the risks versus the benefits of the medication. So the next slides are just a chart comparing methadone versus buprenorphine naloxone. I won't go through it in great detail since I know this has been covered already. I'll just make a few points. So when we're looking at the effectiveness of methadone and buprenorphine naloxone, I would say they're both considered the first line agents for opioid use disorder. So again, these are two good options. In terms of availability, they should be fairly widely available throughout Ontario. So again, patients should have relatively good access to both these medications. So the primary differentiating factor between methadone and buprenorphine naloxone is the safety component. So we know that in terms of efficacy, they're fairly similar. However, in terms of safety, buprenorphine naloxone is considered much safer than methadone, obviously because of its partial opioid agonist activity. So all things being equal, when we look at the guidelines, specifically the CRISM Canadian guidelines, they do recommend buprenorphine naloxone as the first line option versus methadone due to its higher safety profile. Also,